Good afternoon and welcome to Kauai Health's bi-weekly community engagement webinar. My name is Deborah Volison and I'm the Director of Community Engagement for Kauai Health. And we're thankful that you are joining us today and getting your updates and facts about Kauai Health. It's easy at this time to get lost in the political chaos that surrounds COVID-19 and the vaccine, but our goal today is just to keep you informed about what we are doing at our organization. So Gary's unable to join me today, but we have two of our executive team who are filling in for him, and we're really excited to introduce them to you in just a second. But I want to remind you that we post the webinar on our Kauai Health website, and we also put it in our Kauai Health Community Engagement Facebook page. So we're going to cover the questions that have been submitted, and then we are also open to taking chats or emails or text if you have a burning question that you just want to know the answer to. So at this time, I'm going to go behind the camera and we're going to welcome our guests. I am joined today by Dan Elaine, our Vice President of Cardiac and Surgical Services. Dan, give us a wave. And Jag Bath, our Vice President of Ancillary and Post-Acute Services. Hello, Jag.
Hi, how are you?
I'm good. Thank you both so much for taking the time to come and fill in on this community engagement webinar. We have done these webinars since last March when everything shut down. And you guys are very familiar with our community engagement and ambassador groups because you have both probably spoken at those groups several times and you've presented at service clubs. So, but today you get to answer all of the questions that have come in. And so Jag, I'm going to start with you because we always start this meeting out with what's going on with the numbers. This group has watched them go really, really high and they get really, really low. And so where are we at today?
I'm going to look at my cheat sheet here. As far as Tulare County goes, positive cases for the last week, we're at the 3,600 number. As far as positive cases currently at the hospital, we're at 117. 118 today, we were at 117 yesterday. Unfortunately, out of those 118, 3 of them are pediatric patients. Again, out of those 118, about 18 of them are in the ICU and on ventilators. And again, between the COVID ICU patients and then kind of our regular trauma or our complicated patients, we're at max capacity when it comes to ICU beds. We've created pods. We refer to pods as 3 to 4 rooms on a different unit that typically isn't ICU because we're out of ICU beds. So 3 West, I think we had 3 ICU beds there as of yesterday, and then 4 Tower as well, which is one of our regular units. We also had some ICU beds there to manage those patients with that complexity. As far as our employees, we have 64 employees that are currently out, either on quarantine or that are positive, COVID positive. As far as the census goes, we're at max capacity. You probably have heard Gary often refer to our adult beds. We have 344 adult beds, and all of them are virtual full between, again, the COVID patients and then our regular medical patients as well. So that's kind of an overview of our bed capacity and the current numbers that we're dealing with at the hospital.
So Dan, have we seen an increase in people in our county receiving the vaccine?
Well, the simple answer is yes. However, put it into context for you. Our community engagement teams, they watch the numbers really closely. And when I got the questions and started researching everything, depending on what website I went to, it was giving me different numbers. So it's an ever-moving number, but what I can tell you that to date, as of the 7th of September, 219,952 community or Tulare County residents have received a vaccine. So they could be in process of the vaccine, keeping in mind that Pfizer and Moderna are a 2-shot protocol, whereas Johnson & Johnson is a 1-shot protocol. So 219,952 have received it. Yesterday, when I conferred with my expert, Doug Leeper, he indicated that 46.9% of the eligible population is fully vaccinated. 9% of the eligible population is partially vaccinated. So that leaves 44.1% of the eligible population unvaccinated. So again, you look at the age, it's 16, I believe it goes down to age 16 is eligible for vaccinations. So we're looking at eligible versus total population. So 2% per week is what I've been seeing through the month of August, increasing. March of this year, we actually had 105,000 people that got vaccinated. But then when I looked at that steady decline, in August, we're starting to see an uptick off of July with 10,000 more vaccines being delivered in August. September, I do not have those numbers yet.
Okay, thank you. So we're hearing a lot of talk about the third shot or the booster. So clear it up, Jag. Are we calling it a third shot or is it a booster?
Depending, again, kind of what Dan was indicating, what you're looking at, it's really, I feel like they're using it interchangeably, whether it's the third dose or a booster. Regardless, it's kind of the same makeup the first 2 times that you got the shot, so there's no difference in that sense. I will say that it is available for folks that are immunocompromised currently. The FDA approved the Pfizer product for that purpose. Right now, it's been really covered well in the media. September 20th is the date that continues to be thrown out there, that I think everyone's expecting the CDC or the FDA to give that approval. And again, the recommendation there is if you're 8 months, post your initial dosage, your last dosage, that we do know it's wearing off, that they are recommending the third shot at that point. And again, as far as availability goes, if the approval happens, around 9/20, typically it takes a couple of days for California Department of Public Health to give the okay, and it should be readily available. We know we have the vaccines ready to go. It's really just waiting for the approval process. Now, a number of folks have gotten the Moderna vaccine, and they're about a month behind Pfizer when it comes from the approval process. So that won't be available potentially, they're at least 4 to 5 weeks behind Pfizer. And then J&J, they haven't gone for approval yet for their booster or their second shot in their case. So, and again, I think in most cases, even someone that has elderly parents, really looking forward to them getting the third shot because most studies have indicated that it is wearing off over time. And if you want to keep the immunity at a stronger rate, what they refer to titer sometimes, it's good to get the shot.
Okay, so if you got your first 2 doses for Moderna, you need to get Moderna.
Yes.
If they were Pfizer, you need to get Pfizer.
Right.
So if Moderna is lagging, us Pfizer folks are going to be able to get it first. Is that what you're saying?
That's correct.
Okay, all right. So Dan, during the last surge, Kauai Health shut down elective surgeries. Have we done that? And if so, can you explain what an elective surgery is?
Sure. Yes, with the growing number of COVID patients coming into our facility, we needed to, again, take a serious look at the number of surgeries that we're performing on a daily basis. When we initially did this back in November, December, January of this year, it was a more rapid shutdown because of the numbers coming in. This time, we actually are implementing the process. We worked with our medical staff, the governance team that's led by 3 of the physicians in surgery, and we defined the process. What we did is we actually used the tier process set forward by American College of Surgery. So we're looking at elective surgeries. Most surgeries are elective. They're not emergent where they come through the emergency department, but there are outpatient electives that are more what I define as cosmetic, and then there are the elective surgeries that we really must move forward with. And when we put this in place on August 23rd of this year, we communicated to all the physicians that we're going to limit the number of patients that you bring into our facility from an outpatient basis for surgery that will require admission. It doesn't limit them on doing cases that are purely outpatient. We know 100% or great certainty, 99%, that they're going to go home that day. We can still do those, but if there's the high probability, 70, 85%, that we're going to admit, we have to cap it at 3. It's not 3 per physician, it's 3 for the day. We also have to keep in mind that we have patients coming through the emergency department. And when they come through the emergency department and require surgeries, those are add-ons. Those we try to account for, but it's very difficult. So again, trying to hold it at 3. So what do we require our physicians to submit? A surgical scheduling form, a preoperative patient scoring tool, and the surgical necessity form. Then the leadership team in surgery will review all these requested schedules, scheduled patients, and we will say, is it tier 1, tier 2? Tier 1, and I'll read this, this is from American College of Surgeons. It's emergent with loss of limb, life, or organ. If the procedure is delayed, it likely leads to permanent disability. That's emergent. Urgent, with delay in procedure greater than 30 days, likely to lead to an unacceptable disease progression, need for hospitalization, or probable future adverse medical event or extended disability. Any procedure required to expedite inpatient discharge mostly are malignancies. So if you have a cancer, you're coming in for a biopsy, we're going to do it. If you have a carotid, you got to do a carotid endarterectomy, and they're symptomatic, we know if we're going to postpone it, the likelihood of stroke is going to occur, we're going to do it. If you're an open heart patient and you have a high degree of stenosis in some of the major arteries and you're experiencing symptoms, that has to move forward. What we're not doing are cases that if you look at it and within 3 months it's not expected to negatively impact, that's tier 3. And then tier 4 is your elective procedures with no urgency, done solely to improve quality of life. So, you know, that to me is, some of those are cosmetic, like vein stripping for varicose veins. That's an example.
So what about like knee replacements? And while they might not affect you, like you're not going to die, but it does affect your quality of life, those would be delayed?
Some are, some are not. The majority of our, the majority of our total knees are now same-day discharges.
Okay.
But if it's severe incapacitating pain, and this is a question we ask the physicians, we will probably do that patient, but again, limited to 3. And Mondays and Tuesdays were heavy orthopedics and urology days. So it's, again, one of those, it's a call. The physician will say it's urgent. If we have a discrepancy on our leadership evaluating the urgency, then we bring the medical director of the department. So if it's orthopedics or general surgery, and we'll engage them along with the director, Dr. Weissman, and we will decide as a team whether or not this is something that we can allow to move forward.
And we're not the only hospital in our region who's had to do this. Up and down the region, they've had to do this.
Yeah, you're absolutely correct. I think they're actually doing basically the same triaging of the cases, where they used to do elective scopes, which is truly an outpatient procedure to clean up meniscus tears and the like. Those are not being done anymore.
So do we hold beds? Like, you know, you were talking about your emergent surgeries, or like somebody comes in through the ED and they have to have an emergency surgery. Do we hold beds for them?
The reality is no.
Okay.
Again, as Jag already alluded to, we're at 110% occupancy. And, you know, I would answer that in one of my later questions that may be posed, but to hold a bed in anticipation of an emergent surgery coming in when we have 30 to 40 admissions from the previous day waiting in the ED, we can't do that. That's an injustice to that patient that's waiting in the ED for the care.
Right. So I know we're holding people in the ED waiting for beds, but just to play devil's advocate, so we have an emergency surgery that comes in and the surgery is completed and that patient needs a bed and we don't have beds. What do we do?
Depending on the acuity of the patient and what bed that they need, if we can sustain or monitor and hold them in PACU, we'll do that.
What is PACU?
PACU is post anesthesia care unit. So after you come out of surgery, we start the recovery and surgery, and then we bring you to the PACU where we complete the recovery phase 2. And when they're ready to go upstairs, they're awake, they're responding, we would move them up. So if they need a critical care bed, we'll bring them in and we'll hold them in the PACU, or post-anesthesia care unit, until that bed is available. Now, there are times when we get a patient, say a trauma, multi-systems trauma, or a pediatric, where we have to bring them back. We know we're not going to get a bed, but we're going to do the surgery. We're going to stabilize the patient, and while we're in surgery, stabilizing the patient, then we work with area trauma centers, other hospitals, to facilitate the transfer once we're done with surgery.
But in PACU, we can hold patients up to 6 to 12 hours, again, giving bed availability, just like we're holding the patients down in the emergency room.
Yeah.
Until we're getting some, movement on bed capacity upstairs.
Right. So shutting down elective surgeries has a big financial impact on CAWEA. So can you explain that and how it affects the hospital financially?
Well, I tapped into my expert, Melinda Tupper, and I don't know how many people know Melinda. She's our CFO. And this is the answer to it is it has a direct correlation to our financial performance. There is a significant impact. During the months when we had high COVID census and we dropped our surgical volume down, we had a significant loss in our bottom line. So the contribution, or the direct contribution margin for that month, the cash that we get from revenues to expense, it was all negative. And when I looked at that and talked with Melinda, and I said, we as executive team members, we understand the big impact. So talking to my public, how do I characterize it or categorize it? And she said that 1/3 of our operating margin is directly related to surgical services. So 33% of our revenue is surgical services. And they may ask, well, you're full, you have 110% occupancy, and the majority of those are very sick medical patients. And when you look at the reimbursement schemes that both commercial insurance and government insurance have, it's under DRG, so it's capped fees. And surgeries have a higher DRG level than some of the medical patients.
And DRG means?
Diagnostic Related Group. That's something that developed years ago, probably 20, 30 years ago, that says a patient should have this amount of utilization of resources, this amount of length of stay, so we assign this dollar amount to it. And if we stay within that, we break even or do a little better. If we exceed the length of stay and the anticipated resources, we lose money on those.
Okay.
So yeah, there's a direct correlation.
Yeah, I was just going to add, Gary, as he always indicates, it's the lifeblood of the organization when it comes to surgeries. I mean, and again, when you're talking, 33% of your revenue is coming from the surgical service line, and when you have to shut that down, it has a huge impact on your bottom line. It is literally the lifeblood of the organization.
Right. And Dan, you're the driver behind that, and I remember being in the meeting when you said, I think it's time to shut down surgeries. That's kind of a gut-wrenching decision to have to make, because you know that it financially impacts CAWEA Health.
Very true, very true. And it's not only impacting CAWEA and CAWEA Health's financial well-being, it impacts each and every one of the surgeons, but more importantly, it's impacting the community. These are people, we recognize the importance of needing to get the surgeries done, and we want to do the surgeries. However, there's a time when we have to say, slow down, let's postpone. It's in your better interests, and we need to take care of this pandemic that's out there. Again, I want to do the surgeries. My team wants to do the surgeries. The surgeons want to do it, but we have to do what's right and safe for each and every one of you that may be coming for surgery.
So Dan, how long have you been here at the hospital?
October 9th, I think it is. I'll be 20 years.
Okay, so has there ever been a time, do you remember other times that we've shut down surgeries like this?
Other than back in December, January, no. And the only other time we ever would have to shut down surgery or a portion of surgery would be facility related. If something broke in surgery and we would have to take some rooms down, that would impact, but never shutting down because of a pandemic.
Okay. So on a good day, a normal day, non-COVID, COVID doesn't exist, how many surgeries do we do in our outpatient surgery?
Oh, it didn't come with that number.
Yeah, I'm just
I
trying
would
to stump you here.
Say, it probably 35 to 40
Okay.
that we would do, and we run 10 to 11 rooms, and we're still running 10 to 11 rooms, but the complexity of some of the surgeries take a lot longer. But yeah, if we're looking at then we have the add-ons that come in from the ED and those that come in from the acute care environment.
And so now our total is,
We're running 20s to low 30.
Okay.
Could I just add one more thing? And the other thing that I want to be able to share with just the downstream impact as well, because it's not just not being able to do the surgery, but again, a lot of these surgical patients need acute rehabilitation or short stay. And again, if we're not doing the surgery, they don't need those services, or outpatient therapy or imaging for that matter. So there's a bigger impact than just surgeries as well.
Right.
A lot of that follow up after the surgery. Obviously I think as a hospital that has a number of service lines, and then obviously the surgeon has a deep impact as well.
Right.
So.
Right. Are surgeons all amicable to this? I know it's hard. I know
So
it's
far,
hard.
yes.
Okay.
So far, yes.
Okay.
Even at the prolonged downtime that we had back in January going into February, they understood.
Yeah.
These are community members too, and they're healthcare providers, and they know we need to do what's best for everyone.
Okay, thank you. So Jag, let's talk about the Delta variant. We were really hopeful a couple of weeks ago that this was going to fly in and fly out. And we still might be under that timeline. Dan, you're the one who has your little tracker that your magic ball that you're looking into and telling us all of this information. But Jag, we're seeing there are some different symptoms with this Delta variant. A lot of people are maybe complaining about stomach pain and nausea more than we heard back in the beginning of the pandemic. So what else is different about this variant that community members need to be watching for?
As Dan was alluding to, I think a lot of times, we phone friends for information, and I had to tap into Sean, our infection prevention master here within the organization, and really, when it comes to the Delta variant, I'll get into, obviously from the very beginning, and my parents are originally from India, and that's where the Delta variant actually was first discovered. So I've been following it for a long time just because we do have some family in India, and then my wife is from England, and then the next major country where it really hit was England as well. So I think from the very beginning, one thing that's been very common, and then we definitely are having the impact in the United States, is just the high amount of how contagious it is. As far as going from one person to the next, it's much stronger. From the very beginning, I would say, from that standpoint. As far as symptoms go, I would say there are similar symptoms. You're still going to have a cough, you're going to have a fever. There definitely seems to be more nausea, stomach issues, and then probably sinus headaches is another big one that's a little bit different than other COVID variants. But again, after that, as far as the path, is not much different. Once it gets into that more moderate and severe stage of COVID, you're going to be having the same symptoms: shortness of breath, your oxygen levels are going to drop, potentially, it's going to turn into bacteria in your lungs, potentially get pneumonia. There's no difference there. I think probably the biggest difference is on how easy it is to transmit from one person to the other. And really, there's studies out there now that if I test positive with the Delta variant, me potentially giving it to folks is 5 to 8 I'm going to give it to 5 or 8 other folks because it's so highly contagious. And that's what is really early on. A country like India that's highly populated, doesn't have the right resources and infrastructure in place, it was just going rampant throughout the country. England, I will say, it went through a little bit quicker, but again, same thing. And what we're finding also is the impact that because it is highly contagious, that a lot of younger folks are testing positive with the Delta variant. So those are some of the key differences, I would say, on the symptom sides, a few, but again, probably my emphasis is on how contagious it is, and again, how important it is to get the vaccine, because that's what's going to help the spread potentially.
It seems to be a shorter amount of time too. Is it called the incubation period? Where I remember when the original COVID happened, you had between 10 and 14 days that you could go before you. Seems like people are showing the spread and symptoms quicker than that.
Yeah, I think it's within 5 days that they're going to have the symptoms. And I would say, I work the weekends at one of the clinics as a practitioner, and the kids that I'm seeing, they're very subtle symptoms. So it's like a mild cold with a little congestion and a little headache, and they are testing positive. So the symptoms, the first COVID virus that came through was more obvious. This one, very subtle on the onset.
Are we still doing the loss of taste and smell with the Delta? Or are you
We are.
We are.
Yeah. That still seems to be a symptom for some folks.
Okay.
Yep.
So, Jag, the county posted a graph comparing non-vaccinated patients to vaccinated patients. But the question is, what about the patients who have been reinfected? Have we had a lot of patients who previously had the virus?
I wouldn't, I don't know exact numbers, but again, in talking to Sean, we are seeing folks that are getting reinfected. And again, the longer we're in this, the more studies are coming out saying, really, you have a pretty good viral load that first 90 days after being infected, that really the chance of you getting infected within 90 days is very slim. But after that, you are seeing folks getting infected. The other thing is you're also starting to see variations in these variants. So you could have gotten a different variant, now we have the Delta variant, and the chance of getting infected. So we are seeing those cases. Now I will tell you, what we're seeing on a very rare occasion are folks that got infected and then got the shot, the vaccine, and then they also had a breakthrough infection. You are seeing that, but it's at a very smaller number. And again, that's the importance of getting the vaccine. The longer you're waiting after being infected, the less immunity your system has. So the chances continue to get higher. I would say, it's put another way, but I would say, again, 90 days is probably the safe period, but we are starting to see infections of folks. Again, as far as hospitalizations, we've had hospitalization of folks as well.
That have had it and have been reinfected. What about that had it, got the vaccine, and are now reinfected? Have we seen hospitalizations with that population?
I don't know if we have, but again, in looking at the numbers, nationally, it's a very small chance. Again, you just decrease the percentage of getting it more than anything if you have the vaccine. So.
Okay, thank you. Dan, are we changing our visitor guidelines at all, or are we still allowing one visitor?
Yeah, no, we're still allowing one visitor for the duration of the hospitalization. And what I want to remind everybody is that we also have to follow the public health mandate that's out there related to the visitors, where they must show evidence of vaccination and or a negative COVID test within 72 hours. And if they have completed the vaccination, they need to wait 14 days before coming in to visit an individual.
14 days after their second dose? Okay.
Second dose. So that's when we consider them fully vaccinated. And then if it's a 16-year-old, we do allow them. And these are all the guidelines that we had in place already. But we allow 16-year-olds to come in and visit, but they must be accompanied with an adult. And there's always the exceptions, that if we have somebody that's actively dying, if it's a mom coming in to deliver a baby, the support person is going to be allowed to come in with them as well. So a lot of those guidelines are still in place, and I think I don't see us changing them at this point.
Okay. So with the the changes that were made to people having to prove that they were either vaccinated or had a negative test, did we see a lot of pushback from the community, or has it pretty much been received well by the community?
I would say I haven't heard anything about it. Jag, have you heard
No,
any pushback?
No, I think it's, getting the message out. I think we have folks that didn't realize that, but I think people understand. So really haven't heard much pushback. I will say, at least at the rehabilitation hospital, if folks aren't vaccinated and they need to show a negative COVID test, with all the testing that's going on, people are having a hard time finding a place where they can go get a test that they can rapidly get the results so they can come in.
Right.
So we are trying to help them. I know one of my administrative assistants was calling around to help the visitor out, be like, hey, if you go to Dinuba, this is the charge. They can give you the test within 24 hours. So people are being challenged by that part of it.
Our public information team this morning, we met on, and we were talking about that. Kauai, we are just slammed.
Yeah.
All of our clinics, even to get an appointment, you have to go to kauaihealth.org/testing, but you're talking, you can't even get in for a couple of days. And so we're trying to round up all of the resources in the county outside of Kauai Health too, so that we can send those out to people. It is a problem getting in and getting tested, and I didn't think about it from a visitor standpoint, but that would be very difficult if you're trying to get in. So Dan, speaking of visitors, I was told that the Mineral King entrance, so we've opened the new emergency department, and so that's where people were used to going in, but some changes are being made around that Mineral King entrance. So can you tell us where visitors are supposed to go and what happens if they go in that Mineral King entrance?
Well, actually, we're redirecting away from the Mineral King entrance, and in the very near future, we're actually going to be locking down the Mineral King double doors. The reason behind that is, if you can remember, for I would say over the past year, the Mineral King entrance lobby was the emergency department entrance and lobby as we finished the construction for the expansion of the new ED that is now open in the new entrance. And as we occupied the new emergency department, we call it Zone 5, that was in August of 18th. This allowed us to come out of the Mineral King lobby. So preparing the Mineral King lobby, returning it back to its original condition, from a waiting room and a treatment area for the emergency department, we're going to have to close it down for a period of time. And the other reason we're closing this down is to allow us to renovate and bring back up the first floor lab draw area. Many of the people, if you recall, if you came to our hospital, you had to go into the basement next to the lab to get your blood drawn. We've actually designed that to be brought upstairs. So we are closing this down so we can renovate and spruce up the area again and bring all the furniture back into place. And then labor and delivery, because they're right above the Mineral King entrance, we're still encouraging them to come in, and they will go into the emergency department, the new emergency department entrance. They'll be screened there, and then they'll be directed into a temporary entrance that we have that used to be the employee entrance right by the Mineral King entrance. So visitors, vendors, we're redirecting those around to the Sequoia Wing entrance. And once we get everything opened, then they'll be returning back to, you can use it, your lab draws there, labor and delivery can go up. But what we're trying to do is redirect around to the Sequoia entrance. A couple reasons. One of the big reasons is we're still screening patients. And if you remember, we have to screen them for the COVID vaccination or the negative test. And we have to monitor the number of patients going upstairs. So because we're resource limited and as far as staff to staff all these areas, we're redirecting for that purpose as well.
Okay. So we really need our community members to share this information, because we don't want people getting out of their cars, parking their car maybe across Locust, and then going into Mineral King and then being told that they have to go around to the Sequoia Wing. And we don't want them walking, because then they either have to walk through the ambulance bay, or they have to go all the way around Locust or all the way back to West Street. So we need to catch them before they park their cars. And so we're working on getting that information out. But our community members, we're really going to rely on them to help share that information. It's all about before they get out of their car.
Yeah,
Don't get out of your car.
It's true.
Yes.
Okay, thank you. So Jag, if a patient is here for a non-COVID-19 related issue, but becomes COVID-19 positive and passes away, is that patient counted as a COVID-19 death?
Again, it's a bit of a complicated question to answer, so let me back up a little bit. I think from the very beginning in the media, it was indicated hospitals are reporting everybody's dying of COVID. That's what they're indicating on death certificates. The reality is it's not just, one cause. There's a number of causes that are listed on a death certificate. If they had COVID and that was a primary diagnosis that the physician was treating them for, it's going to have COVID on there as a primary principle. And probably an easier way to explain this is, let's say the cause is respiratory distress syndrome is what they died from. Again, that's the main reason they died. Underlying causes might be pneumonia and COVID. Comorbidities of that patient might be, COPD, chronic obstructive pulmonary disease, as well as hypertension. So it's just not listing one thing, but and really the doctor dictates that. Is what's the primary reason of cause of death? If they truly are in here for a stroke and that's a primary reason that they'll be treating for, and they tested positive for COVID, and COVID definitely had an impact of them passing away, it's still going to list whatever the primary thing that they were treating them for first. There's this hierarchy of diagnoses that are listed. And again, not to get into the weeds, but these hierarchies are developed, with a structure in place of, these ICD-10 international classification diagnosis that you got to list on a death certificate. And so there's a methodology that the physician has to follow depending on what the primary diagnosis and what the secondary diagnosis that are being treated, as well as the comorbidities. So a number of things get listed on the death certificate. Hopefully that makes some sense to the public.
Well, people still think we're rolling around in all this COVID money.
Yeah.
And I think that's behind the conspiracy that we're marking them all COVID-19 because we're rolling around in this money and it's just pouring from the sky.
Right.
But the reality is, because it's a communicable disease and because
length of stays are long,
right,
and the resources it takes to manage these patients, we're not able to cover our costs managing the COVID patients.
Right.
So from a financial perspective, we'd rather have the surgical patients back.
Right.
Right.
Yeah.
Exactly.
Right.
So Jag, what is our max capacity of COVID beds that we have available?
I know Dan and I will try to answer this together. Again, let me share with you on what we've had, what our peaks have been. We monitor things closely. A number that I'll never forget was 169. That was our peak January 5th, which we refer to as the third wave. Again, that's how many we managed at one time, the most COVID positive patients. And again, if you keep in mind, we have 344 adult beds and 169 are now occupied by COVID patients. Over half the patients we're managing are COVID. That just means all of our trauma, our normal sick patients from the community, we're managing with less than 50% of our bed capacity. With this current wave, August 25th, which has now been 2 weeks out, we were at 129, I think has been our highest. So we've been fluctuating between about 111 to 129 in the last couple of weeks. But even that 129 is very hard to manage, because I would say before bed capacity, I feel like a bigger impact is staffing. Mm-hmm. It's like sometimes we can create more bed capacity. We have other campuses. We have the acute rehabilitation hospital. We have the mental health hospital. But what it really comes down to is, do we have the right amount of nurses? Do we have the right amount of providers, intensivists to manage these patients, or hospitalists? That's where the challenge becomes. So it's kind of a moving number. We have a team that's working on it on a daily basis, and honestly, it's putting a jigsaw puzzle together of saying, where are we going to put these patients, our COVID patients, plus we have our regular sick patients that we're dealing with as well. And just really, we're obviously trying to cohort all the COVID patients and units, in a certain manner and keep our other folks separated. But it's a difficult thing to manage. But I would say, the most we've managed is 169. But even, I don't know what that exact number would be, but I will tell you it's more dictated by staffing, more than almost our bed capacity. And we'd have to work with other local hospitals, because I think it'd be really difficult, to go over that number. Again, it also depends on the acuity. Because sometimes right now we're hurting more for ICU beds more than our med-surg beds as well. So there's a lot of factors that go into, it's a hard question to answer.
I guess I would say in theory, we have 340 beds. Mm-hmm. In theory, we could have 340 COVID patients. But then we would have no place for anybody else.
Mm-hmm.
Okay, and we referenced last year in your answer, but last year we weren't really dealing with the staff shortages that we're dealing with this year. Flu kind of disappeared last year, and now it's back.
It's here.
Do you know off the top of your head, Dan, how many flu patients we've had this year?
I do not. I would have to get that. But I know, again, working on the weekends, I'm seeing COVID positive flu A or flu B combined. And I'm seeing flu A and flu B independently. So the flu virus is here early. And I think that goes back to last year, where a number of people did not get the vaccine because they were face masked. And it's one of those that there's ramifications on decisions, the cause and effect.
Yeah, but definitely worrisome. As we been talking with the infection prevention team, they are starting to see, like you indicated, increased cases of the flu kind of early in the season. So I know the hospital, we received at least some of our allocation for the flu vaccines as well, and I think employee health is getting ready to start, getting that out for our own employees in our clinics as well. So it's gonna be important for folks to get, again, not only the COVID vaccine but the flu vaccine as well. Because
just line us up.
Yeah,
and just
exactly.
So
vaccines are good.
Yes. So last year, I remember, because everything was shut down, we always saw these surges after holidays. Because we were all shut down, but yet we would try to get that holiday in with each other. But now we're open.
Yeah.
And so are we anticipating any kind of surge from a Labor Day, or is it just kind of...
I would say, to your point, Deborah, it probably won't be as dramatic as it had been when everything was shut down. People were getting together. But again, the reality is it's a time of celebration. People are off. People have a tendency to get together or go out to bars or restaurants. So traditionally, there's always been a bit of a spike after every holiday. The impact probably won't be as much. But what you're kind of hearing nationally that's having a bigger impact on the spread is the kids going back to school. So again, that's why it's important, again, for kids to be wearing masks in classrooms. And really, I think that's where there's some worrisome. It's worrisome is, again, that the kids are getting together, and rightfully so, but that's going to impact the spread more than even the holiday weekend. Because really, throughout the country, schools continue to open up, and there's going to be impact because of that more than anything.
So let's go back up to the beds, because this other question, so what determines the amount of beds available when we report it? So like we might say we have 3 beds available. So are those beds actually occupied, or is it just the amount of nursing staff that's available? This is kind of a confusing question, and I might have said it more confusing than it actually is. Do you know what I'm saying?
I do.
Yeah. The way I interpret that question is, it goes back licensed beds.
Okay.
Again, so I got my graph here because I need numbers in front of me. So we have 237 med-surg beds in our organization. Those are licensed beds. And as of this report, which was September 8th, we had 235 utilized, meaning patients are in the beds, and we have 2 available.
Okay, what's a med-surg bed? What does that mean?
Well, medical surgical beds are we have critical care. Everybody knows critical care. Then we got step down critical care, which is that unit that's immediately after you're out of the ICU, you still need a high level of intensity of care. That's that one. It's a 1-to-3 ratio. Then you get out to your medical and your surgical patient beds. Those are where your general med surg patients like pneumonia, pyelonephritis, kidney infections, post-surgery type of patients, total knees, total hips, laparoscopic surgeries.
Really stable patients, stable patients. You know, I would say when you think of a normal hospital bed, you're thinking of a med surg bed.
Okay, so when you're talking about a ratio, that means one nurse per how many patients, right?
Yeah, so the state mandates a ratio for us. Med surg, standard med surg, 1 nurse, 5 patients. If it's a specialty unit, like a telemetry unit, 1 nurse, 4 patients. ICU step down, 1 nurse, 3 patients. Then you get into the ICU, the true critical care. The standard ratio is 1-to-2, but there are 1-to-1s in the ICU as well. And then there are 2 nurses to 1 patient, depending on the acuity of the patient. Extracorporeal bypass, or ECMO, where we put the patient on a machine that we actually bring the blood out, oxygenate the blood, and put the blood back in. We put 2 nurses on that patient. So these are mandated ratios, and when you get into mental health and into skilled, there's different ratios there as well. And when I looked at this question, and it's what determines the number of beds that we're reporting, it's licensed beds to actual occupied beds. And does staffing come into play? In a pandemic like we're in right now, we staff every bed. Every bed in this hospital is covered by the nurses at the ratios that we need to be at. The difficult area is the ICU. We have 41 beds, we have 41 patients, but we have 43 ICU patients in the organization this morning when I checked. So we're over capacity. So what do we do with those extra patients? And I think Jag already alluded to it. We create a pod, we create a group of patients, common acuity, and we put those on our intermediate critical care units, and they're staffed at a 1-to-2 ratio.
Okay, so you just can't put an ICU patient in a med surg bed.
We
You
can
have to keep
if
them.
we staff it to that level.
Okay.
And if we do a lot of that, we have to notify the state and flex.
I was gonna say, yeah, right now the state is allowing waivers because they know hospitals are max capacity, so they're allowing, organizations to make decisions on using units that typically aren't set up that way. But again, it requires certain monitors to be placed. So clinical engineering is very busy at work.
Right.
So it's just not the nursing, but it's the infrastructure that all of a sudden that you have to create that ICU kind of setup from infrastructure standpoint on a traditional med surg bed. So they have to have the telemetry available, they have to have monitors available, the entire stay. So yeah, it's very challenging. And I know clinical engineering worked through the night one night to get these pods ready from an ICU standpoint.
Yeah.
So one thing I want to say about the staffing, to get to this level, to maintain our staffing levels, the community needs to understand we have 100 plus travelers here in the organization, the highest number we've ever had.
Okay. Yeah. And that's we need it, but that's a huge expense.
Yeah.
It's a very huge expense. And Mark Mertz, our vice president, just chatted in breaking news. Biden has issued an executive order stating that all federal employees must be vaccinated, no exceptions, and all employers with 100 or more employees will have to confirm employees' vaccinations or test them weekly. All right, well, on that happy note, thank you guys both so much for coming, and you guys, thank you. This was a very cool conversation, and I appreciate you going deep into the weeds on some of these questions, and you represented Kauai Health very well, so we appreciate it.
I would say I enjoyed the opportunity every time I get to come over and talk to the public, whether it's to our engagement, community engagement groups, or the public in general, or even our employee huddles. It's something that I enjoy, and I like to share the information. I like to be that source of information. Jake, I think you agree.
Yeah, likewise. I would say, Deborah, thank you for having us. It's always a pleasure, and especially getting us a chance to connect with the community of really what's happening in real time, what our
Right.
day-to-day looks like. So thank you.
Yeah, and what Mark just sent in, it's like, okay, just
Yeah.
we in the last year we have learned to adjust and change more quickly than probably ever before. And it's almost a day-to-day thing. You
Yeah.
wake up and you think you've conquered the challenges of yesterday, and you just get hit with another challenge that you've got to work on today.
Yeah.
So thank you guys both. The executive team has just been amazing through this pandemic. And I want to thank everybody online for joining us, and I really hope you leave this session with more information than you had before it started. And we will post this webinar, and we look forward to seeing you all in person one day.
One day.
One day. Thank you guys again.
Thank you.
We
Thanks,
appreciate it.
Deborah.